A midwife really is the key person in someone's pregnancy, I feel.
Midwives are the experts in normality when it comes to pregnancy, but also labour and birth.
You know, it's a really proud moment because sometimes you do walk away and you're just like, you know, that woman had that delivery because of what I did.
They know you. You're not repeating your story 1,000,001 times. Actually having that continuity from somebody can improve the outcomes that you then gain.
We always say block out the noise, drown out the noise that you're hearing because people love sharing horror stories.
You need to be sleeping, eating and drinking to encourage a healthy pregnancy to continue.
Any kind of bleeding that is fresh red blood, you need to go to the hospital and get that checked out. Absolutely need to go.
Nothing should happen to you and no decision should be made for you. You should be a player in this game.
Leila just did her vows to you. Do
Yeah,
you want to maybe do your vows?
I do. Yeah, I do.
You guys have such great stories. I really enjoyed that one. Hello and welcome to another episode of Uni Babies with me, your host, Dr. Saranya. I'm delighted to be recording my first podcast after giving birth to my baby boy. Today I'll be getting to know two new uni experts, midwives Katie Benyohai and Leila Zahedi. Katie and Leila are senior NHS midwives with over 26 years of combined experience. They are also co-founders of Better Births London, which offers private midwifery services. Katie and Leila led the antenatal journey for uni, covering everything from labour signs to caring for your newborn. They're also a joy to be around. I can't think of more perfect guests for my first postnatal episode. Welcome, ladies.
Thank you so much and congratulations.
Thank you. Having followed your social media, I am so excited to meet you both and it is so great to have you here today.
Thank you for having us.
Great to be here.
As you may know, we usually start this podcast with a segment we call Expose the Expert, a chance for myself and our listeners to get to know you a bit better. So I'll be asking you both some questions, and this is new for me because there's two of you this time. So just answer as quickly as you can, and we'll get started.
Let's do it.
We're ready.
Okay, so do you have a hidden talent that people don't know about?
Leila does. Go on, Leila.
My hidden talent has got... Actually, we realised today that my hidden talent is parking. I'm actually really good at parking in really tight spots. I'm really good.
A useful skill to have.
Yeah, very. Especially when the driver next to you is thinking, or behind you is thinking, hurry up. And you're like, oh, please.
And she can do it quite speedily.
I'm pretty sure I saw your car and I know how difficult it is to get into that space.
My hidden talent is I am a very quick learner when it comes to the ukulele. So my daughter is learning the ukulele and I think I'm going to surpass her in the skill. I'm really good at the ukulele.
You can't outdo your daughter in a skill.
Trust me, everything is a competition with a 5-year-old.
I look forward to hearing it in the future.
Thank you.
And my next question is, if you were a boxer, what would your entrance song be?
Do you know yours?
The only song I've got to mind now is the song my son was born to, which is, what is it? Sweet Disposition by Temper Trap.
Good song.
It builds up. That would be
That
my
bit,
song.
that segment. Mine would absolutely be Pussycat Dolls, Buttons. That's me. And I would have to learn the dance and I'd like do some shadow boxing and dance at the same time. And then I'd find myself on the ring.
I actually did a dance to that at university. Now that I'm thinking back to it, I can teach you.
Can't wait.
And if you had a superpower, what would it be and why?
I can't stand these questions personally because I find them so hard because I'm like, oh, I want to know what people are thinking, but then do I? I don't know if I want to know what people are thinking. And you know, I don't care to fly. So I don't know about, you know, do you have a superpower?
I think mine would be, could I slow down time? I feel like, especially in motherhood, everything goes so quickly.
Yeah.
The days are long, but the years are very short. And I think maybe certain aspects I would want to slow down time.
I think that's a good idea.
A good one.
Yeah. Well, thankfully you have phones for that now.
Yeah, true.
So we're going to do a quick fire round. I'll be
Let's do it.
asking you a this or that, and I want you to answer as quickly as possible.
At the same time.
I guess so.
Let's do it.
Ready? Tea
Go.
or coffee?
Coffee.
Trainers or heels?
Heels.
Trainers.
Day shift or night shift?
Day.
Vaginal birth or C-section?
Vaginal.
And lastly, describe yourself in 3 words, and I'm going to hear from each of you. So, Leila, how about you?
Okay, 3 words. serious overthinker. Those are the 3 I can come up with. I can't think on the spot.
No, that's good. Okay, my 3 words to describe me. I would say passionate.
Yeah.
I would say kind.
Yeah.
And I would say meticulous.
Sounds like Leila agreed with all of the last.
She nodded.
I was like,
she
God,
is.
that was a
She
good
is,
word.
and she is.
I was like, that was a really good word.
Thank you.
That was great, yeah, and good skills to have, definitely. Thank you.
Yeah, love it.
Okay, so moving on. Now, as a children's doctor and a new mum, I've had the privilege of meeting dozens of midwives. And I'm always really fascinated by the stories that they have to tell, especially the ones that tell me why they wanted to become a midwife in the first place. I'd love to hear that from you too. So what inspired you to become midwives?
Go for it, Kate.
So I was at university. I went to the type of school that said you will go to university even if you don't know what you want to do. And so I picked the subject that I loved the most at the time, which was sociology. And it was when I was doing sociology at Leeds that I met somebody who was doing midwifery. This was just on a night out. And she was telling me about what she was learning. And I was like, oh, that's what I want to do. And the modules I was taking was like the sociology of motherhood, sociology of the family, that type of thing. So I was obviously leaning towards that anyway, with a keen interest in how we shape those experiences of being a mother, being a woman, family, anthropology, full stop. And so I contacted the university and I said, hey, want to switch? And they said, no, you don't have the right A-levels to be able to do that. However, if you got a first in sociology, you'd have to apply, but we'd accept you onto midwifery. So that was my mission. And so I made that sociology degree as relevant as I could. So my dissertation was about teenage motherhood, that type of thing. And then I did get the first, and then I started midwifery. But it was purely a conversation on a night out with somebody who it first exposed me to it. I had no exposure prior to that. But I do think it's something innate in people, and my root in was sociology.
Congratulations on your first.
Thank you. Thank you. 2 firsts.
But also two firsts, but also a really interesting story.
Yeah.
And it's interesting that it comes to you when you least expect it.
Exactly that.
Midwifery does do that. For me, I feel like I agree with what you said. It's something that's already in you, but I didn't even know that I had it in me. And been brought up by a single mum, and so that strong female empowerment stuff has it's been deep rooted in me from just when I was a baby. But you never think that you're going to turn something into a career choice. Does that make sense? So I never thought I'd be working with women and helping women through like a really vulnerable time, but being from such a young age, I always knew that was where my interest was. Because for me, the norm was that the woman did everything. My mum did everything. She literally just started from scratch, all on her own, never had a man involved. So for us, it was like, wow, this woman is capable of doing anything. So then when I heard about midwifery and saw my auntie fall pregnant, I was like, whoa, this pregnancy thing is so fascinating. But the thing that got me the most, because I was 10 years old, I remember this really clearly, being a 10-year-old in my family, whenever there's in our culture, in the Iranian culture, it's very much like, if there's a baby there, don't let the young one touch it. Or her, don't let the young one touch her. And I thought, oh, for goodness sake, they're never going to let me carry her. It was really annoying me. The community midwife came to the house and she literally picked her up and she started doing all her checks. And I thought, who is this woman and why was she allowed to do something that they've all told me not to do? And then that's what opened my eyes up to what a midwife is. And just then it fast forward from the age of 10, going into like A-levels and things like that, I just thought, gosh, what am I actually going to do? Because school doesn't really prepare you. It doesn't prepare you to pick something for life. It really prepares you to pass exams, but not to go through life, you know? So I felt like I had to do that all on my own and just really figure out what I wanted to do. And my mum was so against me going into midwifery. She was like, don't do it. The hours are long, you know, the shifts are long, you're not going to enjoy it. And I said, Mum, I really don't see myself doing anything other than just helping women and seeing babies every day. And that's literally how I fell into it.
What a lovely story.
Yeah.
That's really nice.
Thank you.
To know, again, at the age of 10,
Yeah.
that's so young.
Yeah.
But you're absolutely right. I agree with all of the things you said.
It literally is like a spark. It's one of those things that something somewhere down in your life will just like influence a decision and it stays with you. And you might not necessarily think about it any other day of the week. You might never think about it again. But the one time like the one time I saw a midwife and then the one time I heard of midwifery again around A-level time, I said, oh my God, yeah, I think I'd really like that. But midwifery is really hard to get into. So I think even that was just super stressful because the application process isn't straightforward. There's wait lists involved. The cohorts are really small, so you can't. There's about, when I was applying, there was about 2,500 applicants, and only at the time 34 spaces. And I remember thinking, that is never going to be me out of all those people, and lo and behold, it was.
It was.
Well, congratulations to both of you.
Thank you.
What we've learned is that you're extremely high-achieving individuals and hugely driven.
Thank you. Yeah, another word for us.
Yeah.
Yes, another one to add. Describe yourself. So, just for our listeners, explain to us the difference between a midwife and what you do and the care provided by the obstetrician or the kind of pregnancy doctor.
A midwife is is the expert in normality, is the best way, that's the best one-liner I can give. So a midwife is your expert in pregnancy, in normal pregnancy. An obstetrician is absolutely fantastic in a situation where there are medical conditions involved, where the patient becomes high risk and needs more needs intervention, needs monitoring. But I really, in all the years that I've done this, and it has been many years now, 13 years this year, including being a student as well, I have really learned, because sometimes midwives are, in certain countries, they're kind of not looked down on, but they're just a bit like, oh, so, they don't really know what a midwife does. But in this country, in the UK, a midwife really is the key person in someone's pregnancy, I feel.
Absolutely, and I think that's a really key point. So I did an elective in my training in America, and the person that I linked in with at the hospital, she used to be a midwife in the UK, and she was now the director of the maternity unit. And she said, look, we don't have midwives here in Nevada, but I know some private midwives. I'm going to give you a day with them. She said, but don't tell anyone I've done that. And I'm thinking, this is really underground. What's going on? And midwifery is not a recognised profession out there, and so the midwives were very much the witch doctors in this house. It was called Homestead. In this house where people who couldn't afford maternity care with an obstetrician would go to have their babies. So what you're describing there is very prevalent even today in other parts of the world.
Exactly.
In the UK, I do think it is a recognised profession, but it is respected. Midwives are the experts in normality when it comes to pregnancy, but also labour and birth. And so if there are no complications, actually the safest hands you can be in it is a midwife's. And midwives know to identify deviations from the norm, and that's where we refer to our obstetric colleagues.
Yeah. That was a really great explanation. I like the way you've highlighted the normality of pregnancy. And I know for me personally, the midwife was essential in my journey. So something that our audience might not know, but you've kind of touched on already, is that in the UK, maternity care is midwife-led. They may not know what that kind of involves. Would you be able to explain what that looks like?
Of course. So you will, when you book with maternity care on the NHS in the UK, you'll have an appointment with a midwife, and that midwife will do the booking. So they take a past medical history and then they plan your care going forward. So if anything was to be highlighted that would require the input of an obstetrician, they will create that appointment for you. But the journey of pregnancy will still have episodes with your midwife, even if you are under an obstetrician as well. What's really important there as well is that even if, let's say, somebody had type 1 diabetes and they were under a diabetic specialist obstetrician, they would then be under the care of the diabetic specialist midwife. The midwife doesn't go away. You do have midwives who have extra training and are therefore able to caseload that cohort of women based on a medical condition. For the majority of people who have a low-risk pregnancy, they will be under a midwife. They will have that contact with the midwife at regular intervals. If you're lucky enough, you'll get a midwife's mobile number and you can contact that person throughout your journey. And so even if you're under, we used to call it when I was training, shared care, and that used to be an obstetrician and the midwife, or the GP and the midwife. Even if you're under shared care, you still have that midwifery input throughout the journey.
And you've also, again, touched on some of the advantages of having that kind of approach in the UK. Can you think of any specific advantages or disadvantages?
of midwifery care. I think the advantage is the time. I think midwives have more time to be able to afford to women in appointments where needed, but also if you have that regular input from the same person, you then have them in the postnatal period as well. They know you. You're not repeating your story 1,000,001 times. How many times do people say, I went to an obstetrician appointment, it was a different doctor again, and I had to repeat the whole story? Actually having that continuity from somebody can improve the outcomes that you then gain. So I definitely think that's an advantage. Anything else, Leila?
I think just having the advantage of just having a midwife there kind of overseeing your pregnancy in itself is huge, because when it comes to our obstetric colleagues, they are everywhere whenever there is a problem.
Yeah.
Mm.
So a lot of the time, that's all they're seeing. It's problems, and they're brilliant at solving them. With the midwife, because we're with the client wherever they are, whether it's, going well or whether it's not going to plan, we've now got this experience of all angles and all different avenues. And so that, I think, is really powerful, because when we then come to care for women in their pregnancies, we're able to just kind of we're able to not predict, but we can kind of see which avenues it could potentially go down and prepare people appropriately. And I think that is really, really powerful.
And I'd have to agree with you. I had actually quite an intervention-filled delivery, which I wasn't expecting at all, and I mentally hadn't really planned for it. But surprisingly for me, but also reassuringly now, looking back, there was very little doctor involvement. Yeah. And I think I really needed that, just to have that one person by my side the whole time. Actually, it was 2 people because it was across 2 shifts, but still the same person that's just for you, the one-to-one care.
Exactly.
It made all the difference. And actually there were times where my midwife could tell I disagreed with some of the decisions. A couple of times the doctors came in and suggested, I think at this point we should be thinking about having a C-section. And they knew that I was quite keen on delivering vaginally. So I could tell she was there to advocate for me and said, do you know what, I think we could probably leave it a little bit longer. Let's just see, half an hour, things might change. She was right.
Yeah,
things
absolutely,
changed, and I had the vaginal birth I wanted.
That's the thing. And experiences, you'll learn. There's only so much you can learn from textbooks. There's only so much you can learn from listening to other people's stories and things like that. And that's why I say to women as well, whenever women come our way, we always say, block out the noise, drown out the noise that you're hearing, because people love sharing horror stories and people love sharing their, the bad things. But it's very rare that you'll hear of the time where, I literally had 5 minutes before they were going to rush me into theatre, and then it all happened and I got the dream delivery that I wanted. And you just think, see, these things are so possible, but because they're not spoken about, midwives see it, we literally experience it, and so often we walk away from our shifts and we're like, it's a really proud moment, because sometimes you do walk away and you're just like, that woman had that delivery because of what I did.
Yeah.
And it's such a proud moment, because you can proudly say, I changed her experience and I did what she wanted. And sometimes in the system you can't, or sometimes because of other situations, whether it's a clinical situation or whatever it is, it can be really difficult. But when you do walk away feeling like, yes, I actually empowered her and she got what she wanted, it's incredible.
And on that point, it's also that advocacy that you were talking about. Even if it's not the type of delivery they wanted, but you've advocated for them, they've understood, and therefore they've made an informed decision.
Exactly.
They're going to walk away without the birth trauma they may have had if you weren't there.
Yeah.
And so that feeling of fulfillment to go, I've made a difference there, is huge.
Yeah, like I said, my preference list was very far from what the actual reality was. But whenever anyone asks me, how was your delivery, I can only say, to be honest, for what it was the best version of what it was, good. Because I had somebody there to take me through it and also, like you said, advocate for me.
Yeah.
So obviously within lots of specialties, you can then further subspecialise. So, for example, being a doctor, I'm a children's doctor. And in midwifery, there's also the opportunity to subspecialise. Now, Katie, I know you're a maternal medicine specialist.
Yeah.
Can you tell us what that means?
Yeah, so I lead on the maternal medicine service at the hospital that I work in. And so anybody with a pre-existing medical condition would come under our service. So we're talking epilepsy, it could be they've had a kidney transplant, anything, ulcerative colitis. I'm trying to think of the people that I saw yesterday. So anybody with a pre-existing medical condition would come under our service, or anybody who develops a medical condition during their pregnancy. So, I mean, it's very complex clients that we're looking after, but I think the key thing with this specialty is that there was no midwifery input until about 2 years ago.
Yeah.
And actually that was lacking. These are the women that truly need the midwifery input and the advocacy and the empowerment to know that actually quite often they're very institutionalized. They've been in the healthcare system from a very young age and everything's a problem. And all of a sudden they're pregnant, and actually the pregnancy quite often goes very smooth sailing. There's no issue here. So they don't even realize sometimes that they have a choice. You know, so are you planning to deliver vaginally? And they look at us like, can I? And it's like, yes, you can experience this like anybody else, so long as we manage your medical condition. So it's a really important role, having that midwifery as a key part in the multidisciplinary team that is maternal medicine, for sure.
I guess it comes back to what you were saying earlier, bringing that normality back into every situation.
Absolutely.
Which I think for something that a lot of people go through, like pregnancy, is incredibly important.
Yeah.
So one thing I'd love to hear from guests is what your average working day looks like. Can you guys tell me about that?
Oh my goodness. I feel like as a midwife, you're no one day is the same. It's always something so different. So being in the community setting as a community midwife, you are allocated on-call shifts. So for example, if I might be working 9 till 5, and of that 9 till 5, I might be doing a clinic in the morning and then doing some postnatal visits in the afternoon. But then I might then be on call from 8 p.m. all the way through till 8 a.m. that same day up until the next day. And so how that day would look like is you're going to try and obviously get all your workload in. You work as though everything is like normal, as if, you know, it's fine, this is just a normal working day. But then once you're done, you go home, you will try so hard to eat something, shower, try to get some rest. And the second you get into bed, your phone will go. That is a typical working day. Your phone will go and you'll get called in and they'll say, somebody's in labour, you need to come for them. And so you get called back in, majority of the time anyway. You get called back in and you then work as long as you need to help that woman in her birth, and as long as the service requires. So sometimes we are understaffed, as I'm sure everybody is aware with the NHS these days, but there is always like backup plans and everything else. So we are that backup plan where if they've got nobody, then we then come in. And so we come in, we deliver, we do all of our work, and then we leave. And then our day, that's a typical working day with an on-call shift. If it's without the on-call shift, then it is 9 till 5 of clinics, postnatal visits, admin, paperwork, everything.
Do you agree, Katie?
My day is quite different. So I'm going to give you a Monday because that's when my clinic is. So in the door, straight into clinic, we probably see about 12 women. And that is, so it's a specialised clinic, myself, an obstetrician, and also a consultant physician who's an expert in pregnant people with medical conditions. So back-to-back women, and then after that, straight after that, is our local MDT. So any of the highest risk women, we will have them on the list to discuss, and I will have already invited any specialists from their other hospitals, so for example their consultant neurologist. So we'll hold the MDT, that normally takes about an hour, and then I go straight to teaching on the mandatory midwifery update. So that is teaching all the midwives in the trust about the service, the referrals, the number of women we're seeing and who to refer and why. So doing some teaching, and then I will be able to sit down to work through the admin from the clinic. And it is a rolling process because the minute you've sorted out one client, you're then requesting documentation for another, uploading it onto the system, and it is purely about information sharing. My role is very much information sharing and documentation, admin, admin.
But bridging those gaps, of course.
But needed, so necessary,
Yeah.
because you can have a plan from a neurologist that our team don't know about, and then we've made our own plan and they're at loggerheads. I'll tell you something I've learned in my role as a maternal medicine specialist is that there are politics when it comes to different specialties, and it's very polite, but don't want to step on somebody's toes, but I'm right and you're wrong, that type of thing. But it's all very polite though.
So 2 very different days that you've explained to me there. And I guess that must be also very different from your day-to-day in your private roles. Now, I'd love to hear what it was that made you start Better Birth London in the first place.
We love this story.
We do love this story. This is like a bit of a romantic story, and let me explain why. So I, before I met Katie, I was at so I met Katie at an NHS trust when I moved there. But before this, I was working somewhere else, and I just knew one thing that really bothered me was that every time I would deliver somebody, I would always find that they're lying there and they're thinking, I had no idea this could happen. I can't believe, what do you mean they cut me down below? What do you mean I got an episiotomy? Or why did they do, and they were just so confused with what happened. And I would always follow with, did you go to antenatal classes? And they'd say, well, yeah, but they never spoke about this. And you just think, oh my God, like what were they teaching you then? So I walked away from that thinking, okay, we need to make a change. So I tried to set up my own kind of private antenatal classes at the time. Didn't really, I didn't do it the way I wanted to, and it wasn't sitting right with me at the time. Anyway, kind of let that go a little bit, and then I moved hospitals, and that's where I met Katie. And I just remember meeting Katie outside the unit, and it was just this young woman. I was going to call you a young girl. This young woman, and she was on the phone, and she was like, "Can you believe they've just left the carpet outside? They can't do that." And I just remember walking past her thinking, oh, I hope I'm working with her today. She sounds fun. So I went upstairs, and then I sat down on the chair waiting for somebody to collect me, because it was like my orientation week. And lo and behold, it was Katie. And I said, oh my God, it's her. So I remember thinking, my God, it was love at first sight, because I just knew that I was just going to get on with her like a house on fire. So we started working together. We were working in the same team and community. And then it literally took about a year, because I joined there in 2016. And then a year later, we were still talking about...
we did an antenatal class.
Yes, that's it.
We did an antenatal class together because they'd rolled out a new format. So we were doing it together, and we were just bouncing off each other.
It was so fun.
And we were communicating in a way that the women were understanding, and they were nodding and laughing and enjoying themselves and absorbing information.
Yeah.
And I remember Leila had come over to mine. We had our
KFC.
Standard KFC, and she said, do you want to do antenatal classes with me?
Yeah.
And I was like,
The feeling never left my mind, because I always knew I wanted to do it. I felt like there was a huge part missing. And don't get me wrong, I've got many friends who are midwives, many people I could have asked, but there was something about Katie that it was one of those ones where, you know, like when your mum is like, you need to find a man who's educated, who's this. Like Katie ticked all those boxes, and I said, Katie's my man. My God, Katie is my man. We are fit for marriage, because Kate was that person who spoke to clients exactly how I liked people to be spoken to. Her bedside manner, if you like, was perfect. Her tone of voice, she was super caring, but above all, her knowledge was incredible, and I loved that. And I said, that was the missing piece. It was the knowledge. I said, my God, that is exactly what we need, because like you said, we did those classes and we just bounced off each other. It just felt so right. And so we had KFC.
And so we started the antenatal classes, and then what it soon evolved into, and the thing that we both are incredibly passionate about, is how do we leave women truly informed and empowered? And so the service changed into what it is today, and that is the midwives in your pocket, there to answer any questions 7 days a week. So we went from antenatal classes. There are many providers of antenatal classes out there, and we realised that we're passionate about it, but the real passion is that information sharing and that empowerment that lies behind it.
Yeah, definitely. That's the best part.
You guys have such great stories. I really enjoyed that one.
You know, they always say a great story always starts with a salad. Well, ours always starts with a KFC family bucket.
Yeah.
So.
And I also feel like Leila just did her vows to you. Do you want to maybe do your vows?
I do. Yeah, I do.
So, as you both know, I've just had my first baby, and I already could see when I was working during the pregnancy that my doctor brain was starting to shift a little bit. And now, having had the baby, it's completely changed. And I also think the things I learned from being a doctor had also already changed the way my mother brain was going to be. I'd love to hear, Katie, you've got 2 kids. I mean, where do you have the time for that amongst all these fantastic achievements? But also, I'd love to know whether you feel work has shaped motherhood for you in any way.
I think that's an amazing question, because a lot of people, women, will say to midwives, or do you have kids? And they'll trust you more if you've got children, or how old are you is a key question as well, because there's this general societal belief that you need to be older and with children to be a good midwife. And I truly believe that training without having had children is so incredibly powerful, because I can't take my own experience and then shape how I treat other people. I've got to take it for whatever they're telling me. But the one thing I will say is there's this added layer onto me as a midwife now that I have experienced it myself, and I can say things with more conviction because I've experienced it myself. So it's definitely shaped me as a midwife, but I think having had that experience pre-children first makes you, it's just my opinion, I'm not saying I'm right, but I truly believe it makes you a more authentic midwife. You don't have an experience shaping your approach to being with women, being a midwife. So yes, I think it's definitely made me a richer midwife, but not necessarily a better midwife.
And I have to say, I agree with everything you just said. Now, having done it with a child, I, of course, always get asked the same question as well. Do you have children yourself? And it used to actually annoy me quite a lot, because you shouldn't have to do, I haven't taken every medication that I prescribe before I prescribe it. So why does it matter if you've had a child or not? But again, as you say, that added layer, I think it's helpful in some cases.
It's absolutely valuable. And when it comes to postnatal care, so going into somebody's house and supporting them to swaddle their baby, I can now with confidence say you can swaddle, but there's also this on the market, which I use and is so much better than swaddling, because they will just kick the blanket off.
Yeah.
So that lived experience is rich, for sure.
Yeah, it's lived experience, So as you already mentioned, the word midwife comes from the Middle English term with woman, and it is a heavily female-dominated profession. But I was surprised to see a male midwife actually during my journey. I had a male looking after me on the postnatal ward. And I would love to know what you think about how more men could be empowered to go into this profession.
We've actually, the trust that we work at, there's quite a few male midwives, and a few of them have actually progressed quite quickly up into more senior roles. I think it is a very heavily female dominated job, and I think men that want to come into the role need to realise that they are going to absolutely cut through the tension that a lot of women build when they're working together, right?
Literally, if this is an advertisement, men, please come.
Yeah, please.
Please join the labour ward and the unit, because we are so tired of being surrounded by hormones. Okay, so we need you. Okay.
But I would encourage them, because I mean, if ever you ask any of the male midwives, what made you want to get into this? One of them said to me, well, I wasn't clever enough to be a doctor, but I knew I wanted to do something with childbirth. And it was like, no, that's not what it is to be a midwife. Yeah. And he was obviously saying it in jest, but he was very much like, why would I not want to? This is such an incredible thing to do, to empower women in this way. Why would it not be for a man to do that role as well?
I do think, though, the name puts people off, like the job title. Yeah. And I think I would struggle if my job role was, actually I probably wouldn't, because I just thought if I was, I know we don't say it anymore, but if I was a fireman, I'd call myself a fireman. Do you know what I mean? I'm just thinking out loud, but anyway, it's irrelevant now. But there's a name for you would call them a firefighter now. So what is the neutral for midwife? Because you're not going to call them a mid-person.
Mid-officer.
So I can understand why some men would hesitate to come into the profession, but I do think that men can provide such a their role can be so powerful because we never, I mean, me personally, for example, if I had a GP who was a male GP, I wouldn't sit and think of that male GP any less or any more than his female counterpart. So I would trust both. So I feel like with a midwife, it doesn't make you, just like you just said yourself, you've had children, but I haven't. So that doesn't make me any less of a midwife. Therefore, if I'm a woman and you're a man, that shouldn't make you any less of a midwife, you know?
I do think also it's like the ultimate, you've got to be the ultimate feminist to be a midwife. You're there to empower women to become from a woman to a mother, to take on this different role in society, but it's still very feminine. And I think anybody who is passionate about that, you're the perfect person for the job, whether you're a man or a woman.
Yeah, I think that's a great way to put it.
Yeah, exactly.
So one thing our listeners can be sure of, and from this podcast today, is that you're both incredibly funny, but also just really genuine people, and that you love to support students. I also love that about my profession, the fact that you get to nurture younger doctors and medical students and help shape their careers. I think that's really important. If you could give a student midwife today one piece of advice, what would it be?
My one piece of advice for any student midwife watching this would be do not let the system suck you in. And all I mean by that is it will get exhausting and you will get very close to burnout, and you will feel some days like, I don't even know if this is really what I want to do. But take yourself back to your why every single time and ask yourself, why did I want to do this to begin with? Because the client is still the same. The client is a pregnant mother who needs your help. So that bit hasn't changed. Guidelines change, NHS politics change, just working in that kind of, in the stressful environment, yes, that has a huge impact. But drown out the background noise, remember why you're there, and do your job and be with women. If that was your why, just continue with that. That's what I would say.
I think mine would be take every opportunity, because that's something I didn't do as a student midwife. I remember once I was on a theatres placement, and I remember the obs gynae consultant said, do you want to scrub in? He was doing a mastectomy. And I was like, oh no, it's okay. I don't think I need to do that. I would have loved to go and have a proper look at that breast, and I don't know why I didn't take the opportunity. So if you're offered an opportunity as a student midwife, just grab it and do it, because some of those opportunities you won't ever get again. The reason why I find that one particularly important, I'm now looking after somebody who is pregnant, but she's got breast cancer. And I just think, would there have been something that I would have learned in that moment that would be able to support me in what I'm doing now? So every opportunity is an information gathering exercise, and you just don't know what it might be. I mean, I was also offered, when I was on my ITU placement, to catheterize an 80-year-old gentleman, and I did not accept that one because I really did think that's not going to help me in my future path. So pick and choose to an extent, but take every opportunity.
Make an informed decision.
Make an informed decision whether you want to take that opportunity or not.
Both really, really good pieces of advice, and obviously things you can apply to anything. And I can only say to students out there, you would be so lucky if you had these two as your mentors.
We think so. We gossip a lot.
If you came out with me, we do often go for a McDonald's drive-through for lunch. So
KFC for brainstorming, and then a drive-through for lunch.
Yeah, and we just go through all the questions over a Happy Meal.
Yeah.
It's brilliant.
Thank you for that. So most of the women you see are pregnant, and of course this is one of the most beautiful stages of life. And I feel so lucky, as I mentioned already, to have met so many midwives through my journey as a doctor, but also as a mum. And I feel that a lot of women out there actually won't get that opportunity until their first midwife appointment or that booking appointment. Can you walk us through what that looks like?
The booking appointment itself. So the booking appointment is usually about an hour and a quarter in terms of timing. It will take literally up to an hour, sometimes more, sometimes less. Within that appointment, it's an opportunity for the midwife to get as much information about you, your health, your, medical history, obstetric history, if this is baby number 2, 3 or more. Family history, social history, literally everything. There are some questions that women may be asked that they might think, God, why is this person so nosy? And it's not that. It's just, honestly, we don't mean to be nosy. It's just that every little thing can have an impact, and that's why we do ask. So the whole point of gathering all this information is to be able to risk assess your pregnancy from a very early stage, from the earliest point that we can. And in order to by doing that, we're then able to bring in kind of extra scans if that's necessary, or referrals if that's necessary. We can do that as soon as possible, because if we do it last minute, obviously sometimes appointments aren't available, or the people you need to see you need to see them at a certain time in your pregnancy, etc. So the booking appointment is usually just a really long, lengthy discussion. Physically, what would happen is your blood pressure would be checked, your height and your weight would be checked, and they would do a blood test for you. And this is a routine blood test that would be tested, that we test all pregnant women in the UK. It's a screening that we do, and all of this can be found online on NHS websites and official websites as well. So alternatively, you can just contact your maternity care provider, and they can let you know in advance. But for any woman watching this, you will be told all of this at your booking appointment.
It's also, so with regards to risk assessment, getting that baseline, being able to refer early, you're then going to get better outcomes. And better outcomes aren't necessarily a vaginal birth in the water with no pain relief. It could be that a pre-existing medical condition is managed and remains stable throughout. It could be that we've referred you to a perinatal mental health team early on, reducing your risk of postnatal depression. It could be anything. But if we know about it from the booking, we're at that baseline, and an early referral is done, you get enhanced outcomes.
Exactly. Another great thing about the booking appointment for some trusts are that you often get to meet the midwife who's going to look after you for your entire pregnancy. And that's really nice, because that's the moment where you kind of, all those questions that you had that in the first kind of 8 weeks, because your booking appointment is usually between 8 and 10 weeks of pregnancy, all those questions that you had, all of a sudden you've just asked them, and now it's that opportunity for you to be like, oh, so wait, am I going to see you again? And then that's the person that you now familiarize with your pregnancy, and you can get comfortable with them, and you can ask them all these questions.
And how likely is it that you get to see the same midwife?
Depends on the hospital you're booking with.
Depends on the hospital, but also COVID came and really just put a spanner in the works for everything in this world, didn't it? Because prior to COVID, we were doing, I feel that the hospital we were working in, we were doing really well, and women were really getting that continuity of carer. But COVID meant that staffing went down, and just resources and everything else, it all had an impact. So it just meant that we couldn't guarantee that you would end up seeing the same midwife throughout. But I do think it's a great question to ask when it comes to choosing the hospital you're going to book with.
My role pre-COVID was I was the Better Birth Initiative midwife, and that was to roll out continuity of care at the trust that we worked at. And it's based on evidence. There are better outcomes, more satisfaction from midwives, more satisfaction from the women if they see the same team of midwives throughout, not necessarily the same person, but a team of 8 midwives max, and you have their contact details, you get to know them, and then the ideal is that one of them is there to deliver you when you have your baby. That's the ideal. But then COVID came and it completely stripped it back. So most trusts aren't providing the intrapartum care, so when you're birthing your baby, but they aim to provide that continuity in the antenatal and postnatal period, and that's the goal, really.
Yeah.
I think that's also why we wanted to go forward with Midwives in Your Pocket service with Better Births London, because it meant that we saw the benefit. So when Katie was doing that role, I was a team leader of a continuity of carer role as well, and we were one of the first teams to roll it out. And it worked so well, and it was just incredible. But it meant that you had a cohort of women who were having this experience, and then you saw the other women who didn't. And it was almost like you were waving from the bright side, and you were like, oh, it's great here, you should come over, but sorry, there's no space.
But you don't live in the right postcode, so you can't, sorry.
And that just felt really cruel. So when we kind of changed up our our service, it was very much, it focused heavily on having a named midwife and a buddy midwife, or vice versa. And so it would mean that you would have, it's not just one midwife, it's two midwives, because then you're guaranteed a faster response, you're guaranteed a second opinion every time. And I think in anything healthcare, opinions, yes, not too many, we don't want too many opinions, but from the right people, from experts in the field, a second and a third opinion is always so powerful, because something that you might hear from one person might not actually suit you, or my perspective might be very different to somebody else with a different kind of set of experiences. So that was, this continuity of care is really what kind of drove us to push our service the way it did as well, the way it went.
And I think that's a really important thing to have in your care. I definitely benefited from having the same team of midwives. So I didn't necessarily see the same person every time, but one of a few people. And that actually did really make the difference. But actually, having said that, and to reassure anybody that doesn't, I then had midwives during my delivery who were people that I'd never met before, and they were both incredible.
And this is the
it made
thing.
no difference.
But this is what we always say. You want somebody who's expert on the labour ward or in the birth centre looking after you, not somebody who's necessarily worked all day,
Tired.
is exhausted, and is now coming out of their bed having had little sleep, and isn't feeling truly confident with, I don't know, for example, remifentanil pumps, whatever. I'd rather somebody who was absolutely expert with a remifentanil pump.
Day in, day out.
Yeah, absolutely. Yeah. And then I'd rather that midwife that I know come and meet my baby at home and give me that care. Yeah. So I think you're right, to reassure anybody, actually, you want the experts that you need in that moment to be the right people.
So we've talked a lot about the appointments, and in the UK you're entitled to approximately 10 appointments, sometimes more if you've got any particular concerns or your medical history, for example. Now, some of those appointments can be quite stressful. Which of those do you think people find the most stressful?
I think towards the end of pregnancy, when you start querying induction of labour, and then it like you can just see it on their faces. They start feeling like, oh my God, now start the timer, and that's not how it should be, but I can absolutely understand it. I mean, I saw it in Katie with your pregnancy. I saw it with you as well. And it was just, and obviously for different reasons, but it really, you feel like you've just placed a timer on their head, and you're like, well, let's hope it happens. Otherwise you end up going for induction. And the thing is, I'm a very positive induction person. Like, I think you can make an induction very positive, and I don't think induction is awful at all, as long as we prepare for it mentally and physically. But that is also reliant on the midwife having done that preparation with you throughout all your appointments. And often they kind of don't say anything until the very end, the last appointment, and all this information has been thrown at you. And that's when it can become really overwhelming.
Yeah, it's interesting that you've chosen that part of the pregnancy, because I have to completely agree. That was what I found most stressful. It was mostly because I don't think my brain was too forward thinking at the time.
It's not just you.
So I hadn't thought about any of the birth preferences. But luckily, in the trust that I was at, I had an antenatal booklet that included this amazing flowchart and questionnaire. And it was kind of like one of those silly quizzes that you do, but it just told me exactly what I wanted and maybe what I didn't want. And that's what you need to know, really.
Yeah.
As a paediatrician, I see children from birth all the way up to 18, and sometimes beyond that if they have a particularly complex medical history and they haven't been moved to the adult service yet. With the midwifery service, how long after birth can patients be under your care?
So a midwife cares for babies up until 28 days post-birth. So that's where our training stops. Anything after that is purely your own experience. So yeah, official training up until 28 days.
Okay, that's really useful to know. Now, apart from providing antenatal care, you both teach antenatal classes, which you've talked about in this podcast already. So for anybody who's not quite sure whether they want to go through the antenatal classes, what would you say to them?
Do it.
Do it.
Knowledge is power.
Yeah. We stopped doing the classes and we gave the support, but then when we came across things like the uni, the uni journeys and stuff, those are the things that we love. Now, we are huge advocates of people who really want to take their time to do classes because they want to get the information. But if your priority is different and you actually, you're okay with the information that you've got and you're satisfied with kind of reading books or getting it online or wherever else, but you really, really want to make friends, then those are when antenatal classes that are in person are so great, because you tend to meet people who are around the same gestation as you, so same due date, around the same area, usually same postcode as you, and so that's really lovely, especially when you struggle to find mum friends, or you don't know where to find them. But then you've got places like, I'm going to be a little bit biased here, you've got the uni journeys, and I just think, having been on that and having taught that, like on the uni journey, I think that has just been incredible. And when I see the professionals that they've had, I'm like, the information that you can get from uni is incredible, and I can't say, and in your own time as well.
And I was going to say, and the ability to revisit the information as you need to, because you don't know where your journey is going to go. You can start off having a pregnancy that's completely low risk, you have every option available to you, and then somebody has said, okay, we're thinking about induction, and now your thought process might be more, tell me more about induction, tell me more about a forceps delivery, because what happens if I go down that route? So revisiting information as and when you need to. But I think knowledge is power. Ignorance is not bliss when it comes to something like this. You should have preferences and you should understand what your choices may be. And so with that, you need the information to inform it.
I can't agree more. The uni journeys have provided me with so much useful information. But in addition to that, it's useful to then take that information away and then think about the things that you're not sure about maybe, and take those questions to your midwife, and you can fill in those gaps. And for me, that's what I always say, that the uni journeys helped me to bridge some of those gaps, because I don't know if I told you the story before, but I ended up asking a random midwife in the corridor one day at work about my combined test in the pregnancy, because I just got a letter in the post about it. As a doctor, I thought maybe I would know about this, and reading online, I thought I'm reading this with more information than maybe average Joe, but it still made no sense to me. So I had to stop someone in the corridor and ask, and she sat down with me, I don't know where she was going, and went through the whole thing, which was really helpful.
But I think those kinds of things, some people are like, they kind of really shy away from things. They want all the information to be given to them on a plate, which there's nothing wrong with that, absolutely nothing wrong with it. But when you have something that gives you the info, but then means that you do feel like you need to bridge certain gaps, it allows you to stay as in the center of your own care. It allows you to really take control without falling for, you just take me where you want to take me. It keeps you right in the middle where you should be when it comes to your pregnancy or any kind of healthcare situation, and you really are at the center of your own care. And women-centered care is key, I think, in pregnancy.
We say this all the time, you should be an active participant in this. Like, nothing should happen to you and no decision should be made for you. You should be a player in this game. It shouldn't be something happening, and you're just an observer.
And in the same way, I think one thing about antenatal classes that I thought was really good was that my husband was there, and actually then he got the same information too. And again, when he came to the appointments, he had some of his own questions.
Exactly.
Which is important, because we were in this together.
Exactly.
I did antenatal classes, and on the first day they asked everybody, what do you do? And it was coming closer to me. He was like, don't tell them. Don't tell them. I was like, I work in a nursery. And then after that, I was getting loads of questions about nurseries. I was like, I can't actually, I'm going to have to complete. I'm really sorry, everybody, I'm a midwife. But the person who was teaching them was a midwife, and I just saw her face. She went redder and redder, like, oh no, I now have somebody fact-checking me. But it was brilliant. And it was a case of, I need you as my birth partner to understand this. So I think you're right. Having your partner there, taking in this information as well, meant he was then able to advocate for me as well.
Yeah, definitely. So we often like to hear some of the frequently asked questions that you get, and you've kindly shared those with us today. So thank you. And we're going to be going through some of those for our listeners. So first of all, to start with, a symptom of early pregnancy, sickness. Of course, it can sometimes extend all the way through the pregnancy or come back in the last trimester. How do you recommend that your clients deal with sickness?
So with sickness, it is a really, really common symptom in early pregnancy. And this is where a lot of people really struggle to find something that works for them, and there's no one size fits all. Some people respond really well to eating little and often and maintaining your blood sugars rather than allowing them to drop significantly. So that's something we start off by advising. Eat little and often, have snacks in your bag, crackers, biscuit, whatever it is, something every half an hour to an hour so that those blood sugars don't drop.
Yeah.
If, however, you're finding that nothing is keeping it at bay, and quite often it's the nausea that's worse than the vomiting, you can be prescribed something, and women shouldn't be afraid to take medication in early pregnancy. Your GP is only going to prescribe something that is safe for you to take. And there are really, really good antiemetics, anti-sickness medications that are out there that are safe to take in pregnancy. And quite honestly, they shouldn't be avoided. You need to be sleeping, eating and drinking to encourage a healthy pregnancy to continue. Denying yourself those things because you can't keep anything down isn't going to benefit anyone.
It isn't, but also it can be really dangerous. So it's important to know that, because if we then get too dehydrated, we also increase our risk of things like blood clots and stuff like that, which if somebody is experiencing things like sickness, then often they're not seeing anyone for the very first 2 months anyway. So who are they touching base with? Who can they speak to? And so, you know, you've seen your GP once, maybe, if that, and then you don't have access to a midwife until you're 8 weeks pregnant at least. And at that point, you're like, well, that 8 weeks is a really long time to feel really sick and not know what to do with it. So naturally you turn to Google, and then Google will tell you these horror stories. But we need to be spreading that message far and wide that in that first 8 weeks, if you don't know what to do, absolutely nausea, you know, we've normalized vomiting in pregnancy, but it can become, you know, it's very debilitating, but it can cause complications, severe complications, and we need to treat those things. So a message to anybody who's listening: if you are suffering, then please do go to A&E, hospital. Absolutely do get help.
And there are charities out there as well, Pregnancy Sickness UK, which are really, really beneficial. So there's always going to be somebody that can support you through it.
Yeah, and one thing we didn't touch on earlier is the maternity helpline. I know you've both mentioned it a few times, but that's always there, and I definitely called it a few times. Found it so helpful during my pregnancy. 24/7. There's never a time not to. But again, with these things, you don't know those numbers until you go for your booking. But hopefully, when people listen to things like this podcast here, they'll be able to know, okay, great, I didn't know I could just Google the maternity triage number for the hospital that I want to book with, and then they'd be able to get access to them 24/7. So that's really helpful. Yeah. So we've talked a bit about vomiting, and some women do experience vomiting and dizziness as signs of low blood iron. Now, this can be quite common, actually. And if you are one of those women who has low blood iron, how and when should you be supplementing?
So when it comes to things like, when it comes to anemia, which is low iron levels, it's a really, really common complication, if you like, condition in pregnancy. It's one of the most common things that you'd experience in pregnancy. One of the reasons why we retest your blood test at around 28 weeks is because your blood volume actually increases. So you've got way more red blood cells, but then those red blood cells are not filled with iron the iron stores aren't in there. And so that's where you then, because your blood volume is increased, you now look like, when we do a blood test, it looks like you've got less iron, because for the amount that you now have, you do have less iron. And so that can make you feel very tired, very sleepy, just really weak, just dizzy, as you said, and sometimes can even cause heart palpitations as well. So the symptoms can be scary. As I said, it's really common in pregnancy. There is a hormone in our body. Is there not, Katie? You explained this really well.
Hepcidin.
Yeah.
So if you have been told from around 28 weeks that you should supplement with iron supplements, you need to be taking them every morning on an empty stomach. And that's because hepcidin, which is the hormone that helps you to absorb iron, drops. And it takes about 48 hours to drop to its lowest point. So you want to take your iron supplement first thing in the morning on an empty stomach with some orange juice, because the vitamin C will help. But first thing in the morning, so that you've got that low hepcidin level. So be really religious with it, and you will find that your iron level does increase. It's important to remember also, from the beginning of pregnancy, you can take a multivitamin that will have an amount of iron in it, but also think about your diet. When the nausea disappears and the vomiting has subsided, think about iron-rich foods that are going to boost your iron level, knowing at 28 weeks we're going to recheck it, and it's likely to drop. We just don't want it to drop too much, and then you end up on iron supplements.
Yeah. the most common pieces of advice that people get given is, oh, it's really low, so take 2 a day, take 3 a day. And actually all we're doing is overloading ourselves with iron, and it's not going to benefit us. If anything, it's only going to make us constipated. So the recommendation, if you are low in iron, obviously always follow the advice from a doctor. This shouldn't replace anything that a doctor has told you. But consider taking it either every other day for it to be easy on your tummy, for you to be able to absorb it because of the hepcidin hormone that Katie mentioned, but also if you have to take it more than maximum once a day, max, because any more than that, we're just wasting the tablets.
Thank you for clarifying that. So one of the more scariest symptoms is bleeding in early pregnancy, and of course if you experience that, I'm sure you'd be straight on the phone.
Of course.
What's the kind of advice you would expect if you were to call?
Bleeding, as you said, can be really, really scary for anybody, absolutely anyone. And I think even if, there are people who I know personally who said, I wasn't even planning a pregnancy, but the second you find out you're pregnant, and then if you start bleeding, the first thing that goes through your mind are things like miscarriage, and you get very, very scared and anxious. One thing to know is that any kind of bleeding that is fresh red blood, you need to go to the hospital and get that checked out. Absolutely need to go. Okay, so that's A&E. But there are times, what I don't want people to think is that naturally your mind will go to that one place, which is always the worst place. It's the darkest place. But there are times, and we have seen it, where somebody might have a bleed, or they do experience a bleed, no matter how heavy or how light, and even we've been shocked where they've gone for a scan and actually everything's been absolutely fine. So that's not to say that, oh yeah, that's absolutely what's going to happen, don't worry at all. There is cause for concern there, but try not to overthink it. And I say that honestly, I know that it's hard not to, but try, from the girl who called herself the serious overthinker, try not to overthink it, and just take yourself to A&E and get seen. Don't Google your symptoms. Don't look for reassurance elsewhere. Just go to the hospital. If you can, get a scan, and they will check you and they will confirm whatever it is for you.
Every bleed throughout pregnancy should be investigated. Yeah. So reassurance only comes where there's an investigation carried out.
Yeah. And if you're not sure, to add to that, you can always call that helpline, because that's what Absolutely. I did. And actually, I got some reassurance on the phone, which was the first thing I needed. And obviously calling, you always think of the worst thing, as you say. And that person on the end of the phone was just so calm and said, look, keep an eye on it. If by this time in the day it's like this or like this, come back to the hospital. We'll look into it.
And I think that's where people really panic, because there are certain bleeds that we expect. For example, if it's the end of pregnancy, you've just had a sweep and then you've gone home and there's some brown discharge in your underwear. Sometimes, again, this needs to be guided by your midwife or doctor, but usually that's not usually a cause for concern, and there's a reason. But that's why the colour, the consistency, the amount, all of this is important. So it's not one of those things where I can just Google it. You have to ask somebody to be able to discuss it and explain what it is that you've experienced, when it came, when it started, has it finished, how heavy, how light, what colour, and then you'll be able to get tailored advice. That's the most important thing.
Yeah, that's really helpful. So one of the more exciting parts of the pregnancy are the growth scans, because you get to see your baby, and it's obviously a wonderful experience.
Exciting.
You're smiling,
yeah,
because I know you love it too.
But sometimes it causes so much more anxiety.
It does, and that's what I was about to say. Of course, when you get told something like the growth is maybe slowing down, or the baby's not the size that we expected, that can be a real worry. How do you reassure those parents?
We get this question more frequently than you'd think. Yeah. And I think one of the things we always ask people who contact us, was it the same sonographer as at your previous scan? Because there is going to be some element of interprofessional variation when it comes to things like this. Same as if a midwife is measuring your abdomen, measuring your baby abdominally, there's going to be interprofessional variation that's going to impact then where that plot sits on a growth chart. So I think the first bit of reassurance is, was it the same person? And if it wasn't, we have to expect a bit of variation there. What's really important with growth charts is trajectory. So if your baby is growing consistently upwards, that is a good sign, and that's a reassurance. If, however, there is a significant drop and the trajectory completely changes, it doesn't follow that line on a graph, then further investigation needs to happen. Of course it does, but we shouldn't jump to the worst case scenario, and that's that the placenta is not functioning as well as it should. We should explore what happens at the next growth chart, at the next scan, the next growth scan. The other thing is this: babies have growth spurts, like we all do. Depends on how much nutrients we've taken in, and I'm talking about how many KFCs or McDonald's Leila has eaten, as to where she sits on the scales, right? So we have to expect over the course of a pregnancy the peaks and troughs of a growth process. Remember also, we can only scan, there needs to be 2 weeks between scans, there needs to be 2 weeks between measurements of the abdomen, and that's to allow a baby a chance to grow. So it's so important we let our minds run away with themselves, but actually we should rein it in, ground ourselves and say, right, what are the variables here that we can control? And if we can't control them, we have to accept the process, but return for the next scan, you know? And there's other markers on a growth scan of how the placenta is functioning. No one's going to allow you to return home if the placenta is clearly not functioning well. Exactly. They will admit you at that point.
Yeah.
I like to say to women is that if it was a real concern, they would not have let you go. Like, they would have advised you to stay and had that discussion about induction or their concerns. So you wouldn't have left that hospital being made to feel like, oh, something's terribly wrong, but just come back in 2 weeks. No, they will let you know, we're really concerned because of this. This is what we would like to do. So if that's the conversation, absolutely. But then if the conversation is, growth is kind of tailed off, but come back in 2 weeks and let's see. Well, they're not 100% accurate.
And if that is the situation, we always say to people, keep an eye on baby's movements. If your baby is moving well, fab. If at all the movements slow down, make your way into the hospital via maternity triage for an assessment.
Yeah. And I think one thing I would add to that is that there's always somebody, again, to assist you on the other end of the phone.
Exactly.
So please do not hesitate.
Yeah.
So I know you've met one of Uni's experts, Dr. Shri Datta. She's our expert for preconception and pregnancy. And she was telling us that she gets loads of questions about nutrition during pregnancy. Do you also get these?
All the time. But our questions will be, girls, I'm just at Ivy Asia and I don't know if I can have this on the menu. What do you think? And it's like, right, okay. Is it raw? Then no. It's like, damn. They almost come to us because they want us to be like, yes, you can.
Yeah, sure,
it's
you
like,
can.
no, we're not going to say that.
Yeah.
But it's always the cheese questions. Around Christmas time, we get it so much more. It's always
cheese, the pate.
Yeah, that's it. Exactly. Yeah. And then just the random questions, like they'll ask like, oh, girls, I really fancied this on the menu, but I'm just not sure. And I've Googled it, but it's like, but why have you Googled it if you're going to ask us anyway? So don't Google it. And also, why is Google lying? Because you absolutely can have that. So they'll literally skim through the entire menu and ask us sometimes.
Well, it must be quite difficult. I mean, I can tell you it is very difficult because there's no one internationally approved guideline telling you each type of food. I was hoping there would be an app out there and I could just search cheese and it would tell me which ones I can and can't
Listen,
eat.
that needs to be our latest thing. We need to scan a barcode.
Get on this, guys.
Yeah, scan the barcode. For anybody listening, this is going to be patented.
Yeah.
So don't try it, and it will be coming.
Unfortunately, it won't be evidence-based though because it's a bit unethical.
Yeah.
To test these things.
I remember about a month after my son was born and you could start having dippy eggs if they were red line stamped.
Yeah.
And I remember thinking,
Oh my
but
God.
that's my last pregnancy. I can't have a dippy egg in pregnancy. But it was life-changing for me. So yeah, this is the other thing. Guidance changes,
Yeah, it does.
you know.
It does.
And so a really good source to go to is the NHS website.
Yeah,
if you're based in the UK, go to the NHS website and there's a really clear list of foods to avoid.
I think the other thing to remember is that guidance is exactly that. It is guidance because you've got certain cultures that eat certain foods and then other cultures and countries that don't touch them. And so, you know, and not to say that, you know, follow what they're doing or whatever. It's always go with the guidance that is in the country that you're living in and is associated to yourself and the foods that you eat. Go with the evidence and, you know, that's all we can go by. If there isn't, then just go with caution, you know, just be careful.
Yeah. And I think that goes with everything.
Everything.
So we've mentioned a bit about fetal movements, and I think that's another thing that can be quite anxiety provoking because there's no one standardized kit count, say. How do you advise women to monitor their fetal movements?
When I was a student, I remember the advice used to be you need to count 10 kicks a day. And that was the thing. And then we came away from that completely. And then it became a pattern of fetal movements. And that, I cannot stress the importance of that enough, because it is all about a pattern. Because if you are used to your baby moving 2 or 3 times a day, but that is the norm for your baby, then that is your pattern. If it's more than that, that is your pattern. So my advice as a midwife to anybody who's listening is to make sure that you are really tuning in with your body from 28 weeks onwards. That's the importance, because from 25 weeks, you'd expect to feel daily movements with no true real pattern to it. But then between 28 and 32, there should be a pattern that's established. Once you establish that pattern, it's about sticking to that pattern every single day. But that doesn't just mean about a reduction in movements. That also means if the baby is overactive as well. So anything that is out of the baby's norm and out of the normal pattern needs to be checked. If you think about it, it's the only way that your baby can tell you and communicate with you that actually something's not right here. And more often than not, that is not, baby is communicating that I just wanted to wriggle or I just wanted to sleep. And that's fine, but we don't know. And so that's why it's always better to be safe than sorry, always. So the advice there is any change in fetal movements or away from the normal pattern, go into your local maternity unit. And that doesn't mean that even if you are away on holiday or if you are, away from your local maternity unit, you don't need to go back all the way there. Go to your local hospital. Tell them that I've got reduced movements and I would like to be monitored. And they can absolutely do that anywhere. It's not a problem at all.
I think it's important that you also highlighted that more movements than usual can also be abnormal.
Yeah.
That's not something that's often mentioned. We always talk about reduced fetal movements.
And also the guidance or the advice that used to be have something cold or sugary to drink, that's been disproved. So waiting at home and having, a Mars bar and some ice isn't going to make your baby move if there are concerns with regards to the placenta. Yeah. So there's no point wasting time. You're to go in and don't overthink it. If something is telling you, I think there's a change here, go in. That's your indicator. There has been a change to the normal pattern.
Yeah, and that's what I would say to friends also. And actually, for me, I think it was really great that at every appointment, my midwife asked me, and just to check in, what are your movements like? And it's very interesting because the appointment that ended up with me being admitted and induced was just before the end. She went, oh, and just quickly, what are your movements like? And then I said, do you know what? I actually haven't really appreciated them that much today. And then she was like, right, we're going to admit you.
Yeah, let's
and
go
then
in and get it
48
checked.
hours later, I had a baby. So
it is funny, though, because I do find that often women ask the question in hope that they already know, in their gut feeling, they know that, okay, it's not been normal, but I'm asking you because I'm hoping you're going to tell me it's probably fine.
Yeah.
So they ask with the hope that you'll say, it's probably fine, don't worry, because they want that reassurance. You're never going to get that. Like, I'm just letting everyone know now. If you're coming with a movement, you're not going to get it. You shouldn't get it from any midwife. And I'm letting you know now in advance, you absolutely need to call the hospital. And you know what? You will feel so much better for it. Yes, it's annoying to go in. And yes, nobody wants to go in because you'll probably end up waiting for ages just to be seen by the doctor afterwards. But at least you can go home feeling reassured that everything was checked and everything was okay.
yeah, and I could definitely vouch for that.